It is my pleasure to introduce this webinar from the International Society of Gynecological Society that is sponsored by Beatrice. The title of the webinar is Patient's Perspective in Front of Hormone Replacement Therapy, HRT. And for that, we have a wonderful faculty because we have Dr. Katrin Schaudig and Professor Andrea Genazzani. Just a brief introduction of both of them, although they are so known that they don't really need it. You will have also myself. I am Professor Antonio Cano from the University of Valencia. I will be the moderator of the session. Professor Genazzani is President of the International Society of Gynecological Endocrinology. Since 1980, he's full Professor of Obstetrics and Gynecology, has been nominated since then Director of the Department of Obstetrics and Gynecology at the University of Cagliari, and then Modena, and finally Pisa. He is the Editor-in-Chief of Gynecological and Reproductive Endocrinology and Metabolism, GREM, and past Editor-in-Chief of Gynecological Endocrinology since 1997 until 2019. He's also the editor of Frontiers in Gynecological Endocrinology, Springer, since 2014, and author of more than 850 papers in peer-reviewed journals and editor of more than 45 books. So he's so known that probably he doesn't need that I specify these titles, but it is how it is. And then we have Dr. Katrin Schaudig, who is a German gynecologist and specialized on gynecological endocrinology. Dr. Schaudig studied medicine at the University of Heidelberg and the Technical University of Munich before completing internships in Munich and the University of Colorado in Denver, Colorado, in the United States. From 1993 till 2002, she was a junior partner at Endocrinologicum, a big private institution specialized in reproductive medicine and gynecological endocrinology. This was founded by Professor Leidenberger in 1979 in Hamburg, Germany. It is a real pleasure. I know Dr. Schaudig since some time. It's always very pleasant to be with her, and she's an excellent speaker and excellent endocrinologist in the area of women's health. So you know that you have also the option of chat for raising your questions. We expect many questions because the topic is very important, very important for debating, and I'm sure that you will have many points to be raised and to be discussed with the speakers along the debate, which will be the end of the session. Just completed this point, I will just introduce the session by presenting my own slides, in which I will just present a very basic aspect related with the topic of today. So if I, yes, this is my slides. So this is the title of the seminar that I have already introduced. You will see that Professor Genazzani will speak about the topic HRT in the past and now, lessons learned. And then Dr. Schaudig will speak about how to approach reluctant patients. I have just presented this slide in which you see that there is a change in the world population. See on the left that there is almost 8,000 million people in the world, and that there is an important area which moves from 50 years old till the end of life. If we move to more industrialized countries, like for example Western Europe, see that the pyramid is not a pyramid, but there is an important increase in the size of the population between 50, 54 and older years, in which there is an increase, a very important increase of this population. And there is many women, obviously, and these women are symptomatic because of menopause. This is data from the SWAN study, the study of the women's health across the nation, in which you see how vasomotor symptoms, which are an important part of the symptomatology of menopause, increase and changes depending on the ethnic origin of the women. There are some differences, but you see that in the early perimenopause, something like 50–60% of women complain of those vasomotor symptoms. But it is not only those symptoms, but also the impact at the level of health. And you see here a representation of the different areas in the body which have estrogen receptors, and the impact of the fall of estrogens at the level of the bone, and also in comparison of the bone with other areas of interest in health. You see that there is a loss of bone mineral density in the years around menopause, but it is important to stress that the mortality, the percentage of mortality of breast cancer, for example, is similar to what is results from hip fracture. So this is something to be considered, because this is very important for considering the impact of menopause. And then just to end my introduction, you see that because of misunderstandings or wrong views about the impact of the menopause hormone therapy, you see that there has been a reduction in the use of hormone therapy in all countries. This is data from the States, and you see how in the years around the publication of the Women's Health Initiative study around 2002, you see that there was a decline in the use of hormone therapy, which has been lower and lower in the years that followed that publication. So this is an important issue. We all are aware that this is something that needs to be clarified in order to provide the best for the health of women. So this is that was my introduction, and now we just have the other speakers. After that, we will have Dr. Schaudig, Professor Genazzani, sorry, first
yes.
His presentation.
Thank you, Antonio. I will share my presentation. And first of all, thanks to be with us. You know, I have the pleasure on behalf of the International Society of Gynecology and Endocrinology to thank Viatrix for the vision that they have. And then I would like to take that opportunity today to speak about menopause hormone therapy in the past and now, and what are the lessons learned. We have to go and to start from the beginning of our history, and this is my disclosure. And I would like to start with you what happened since starting from 1980 to 2000. And we had a series of observational studies and clinical experience who were pushing menopause hormone therapy for prevention, apart the treatment of symptoms. And in fact, I would like to start with you with that study in 1992, published in Annals of Internal Medicine, who give you the important message rising from, this was written by Deborah Grady and many others. And in their review, their conclusion was that there is evidence that estrogen therapy decreases risk for coronary heart disease and for hip fractures. But long-term estrogen therapy increases risk for endometrial cancer and may be associated with a small increase in risk of breast cancer. The increase in endometrial cancer can probably be avoided by adding a progestin to the estrogen regimen for women who have a uterus. And hormone therapy should probably be recommended for women who have had an hysterectomy and for those with coronary heart disease and high risk for coronary heart disease. You see that starting from that vision, the entire world of internal medicine and general practitioners, they were pushed to the use of hormone therapy in women, not so only for the treatment of the symptoms, but for the protection of coronary heart disease and it's the risk of cardiac death. And certainly they have that idea that a progestogen, they were speaking about progesterone, they have not clear that progesterone is something, and progestogen, they can have also some atom different effect, but a progestogen is needed to protect from endometrial cancer. That was the time where also we start knowing that an individual, this is a beautiful data from Bob Lindsay published in 1987, that if you take an oophorectomized population and since the oophorectomy, you start an estrogen replacement therapy, you can maintain the bone mass. If you start after 1 or 2 years after the oophorectomy, you can regain the bone mass that the patients have lost. But if you start later on, you can maintain, but you cannot regain the bone mass lost with the oophorectomy. Then it was clear that the bone can be protected at any age, starting since the oophorectomy or since also the natural menopause can be protected. With this in mind, we went on. And in 1995, it was a very famous PEPI trial, the postmenopausal estrogen progesterone intervention trial, who clearly show that going to the biological parameters which are important for the cardiovascular risk, in comparison to placebo, estrogen rise HDL cholesterol, reduces LDL cholesterol, and increases triglycerides for the effect on the liver. And if you add MPA, either methoxyprogesterone acetate in a cyclic or in a continuous way, you can reduce the positive effect of HDL, or you can still have an important reduction of LDL, and you don't modify the effect on triglyceride. If you add micronized progesterone, then you go in something more natural. You can maintain the HDL rise and still have an LDL reduction and triglycerides increase. Then there were the data showing that the cardiovascular risk can be reduced. And in fact, a general study evaluating all the observational studies on estrogen replacement therapy and hormone replacement therapy and cardiovascular diseases, they show that the relative risk of cardiovascular death was absolutely reduced in nearly all studies. Only Wilson in 85 found an apparent increase. But when these data were published by Petitti, excluding the women of 65 years and over, then women treated very late after the menopause, you can see, this Petitti shows that also the Wilson data clearly indicate an important positive effect. This was the spirit that we have. Once in 2002, we met in Berlin, I remember, at the International Menopause Society Congress, and enthusiastic to go on with hormone therapy. But a few weeks after the Berlin Congress, Women Health Initiative study was published in its first issue. And this Women Health Initiative is a long-term national health study that focuses on strategies for preventing hair disease, breast and colorectal cancer, and osteoporotic fracture in postmenopausal women. Then they had seen at this stage that these chronic diseases are the major causes of death, disability, and frailty in older women of all races and socioeconomic backgrounds. It was a multi-million-dollar, 20-year project sponsored by the National Institute of Health, National Heart, Lung, and Blood Institute, testing the health effects of hormone therapy. Hormone therapy means conjugated equinestrogen plus methoxyprogesterone acetate, dietary modification, and or calcium and vitamin D supplementation, or to an observational study. The study was a double-blinded, placebo-controlled, randomized clinical trial conducted among US postmenopausal women of 50 to 79 years at the enrollment, 50 to 79 years. And to have a so long study in individuals who have to be enrolled from 50 to 79, one exclusion criteria was the symptoms. The highly symptomatic for the menopause symptom, they were excluded. And the trial tested the most common formulation of hormone therapy in the United States, conjugated equinestrogen plus methoxyprogesterone acetate for women with an intact uterus, and conjugated equinestrogen alone for women with hysterectomy. The CE plus MPA trial was stopped after 5.6 years due to an apparent increased risk of breast cancer. And the CE alone trial was stopped after 7.2 years due to an increased risk of stroke. But what happened? It was that this study at its appearance, its publication was done, and these have an immediate, very important effect on daily press, not only daily press. I show you here the magazine Time, the truth about hormones. Truth about hormones was that this indicate an increased risk of breast cancer and increase of stroke in the only estrogen-treated individual. And this, we had immediately a strong reaction. I was at NIH in Bethesda when they presented the study, and we immediately tell them that the study is not corresponding to what we are doing in postmenopausal women. They were excluding the symptomatic women, and the symptoms just clearly represent a fragility of the individuals. And it's certainly clear that probably if you take out the only to treat the non-symptomatic, it's not right that they represent the whole population. And in other side, they were treating individuals starting from 50 to 79 years. That means individuals who were already from 5, 10, 15, 20 years out of the menopause. And as you know, these make a complete changes and restructuring of a series of biological situations, such receptor distribution, neurotransmitter production, and so and so. And also, in addition, the study was published without a well-completed analysis to evaluate if all the data that they're bringing as risk, as facts, they were really true or not. And then we have made a series of studies and publications against that one, indicating that for us, the study are not representing exactly what happened. And in fact, the results of the publication was that we have closure of pharmaceutical factory. I remind Wyatt and producer of conjugated equinestrogen, patient deprivation of a good therapeutic option, 63% of total reduction of prescription. In Italy, for example, in my country, they remain only 6% of prescription. However, if you go inside to their data, the reanalysis of Anderson, who published in 2012, clearly show, taking together the CA plus MPA treated patients and the placebo group, the CA only treated patients and the placebo group, you can see that the placebo group of both population don't have absolutely any difference one from the other. What is the difference is that CE alone reduces the incidence of 23%, the incidence of breast cancer, while CE plus MPA increases the risk. This what indicate? This indicate that in comparison to no treatment, conjugated equinestrogen alone reduced the expected cancer incidence, but if you add medroxyprogesterone acetate, this not only bring back the results to the placebo treated, but even grow even more. Then the problem is not a problem of estrogen, the problem is a problem of the progesterone. And in fact, already the French, they have published, and we have several data on that point. I want to show you the slide done by Fournier in 2005 with nearly 55,000 postmenopausal women, 25,000 HRT versus 30,000 non-user, mean age at inclusion 52.8. More representative of what really is the menopause, followed for more than 5 years. And you can see that estradiol, women treated with estrogen only, also in that study, they don't have any increase. The increase went when they were treated with estrogen and progestin. But synthetic progestins, they rose 1.5 is the relative risk, while micronized progesterone added to estrogen don't give any increase. That also in our study, in these studies, there is a difference between the effect of the various progesterone. And When the WH trials data on stroke, they were reanalyzed, and then you can see here the confidence interval published and the adjusted data published. You can see that the risk, which was apparent at the first publication, completely disappeared. Only in the WHI trials, the population treated don't show any increase, any significant increase in stroke. And in the other side, what happened, and it was also clear from our data that we had in Europe, that oral administration of estrogen increases venous thrombotic risk for the effect on the liver, while transdermal estrogen, they don't rise. But also micronized progesterone don't have any increase in venous thrombotic risk, while norepinephrine derivatives they have. Then there is also a difference between the way of administration and also for the venous thrombotic risk, a difference based on the quality of the progesterone. Then we start in Europe a lot of studies, and the first one who started the beginning of the reevaluation of hormone therapy was the Danish osteoporosis study, the DOPS. This was published by Schaudig. She was a study on more than 1,000 healthy women with recently postmenopausal, 500 treated with hormone replacement therapy, which was a triphasic estradiol plus noredisterone. And noredisterone is not a total innocent progesterone. And 500 controls, women who had hysterectomy, they were treated only with 2 milligrams estradiol per day. And the intervention was stopped after 11 years, but the women were followed up till 16 years. And primary endpoint was a composite of death, admission of hospital for heart failure and myocardial infarction. And you can see, first of all, that we have data on deep vein thrombosis with an overall risk of 2 in comparison to non-user, but neither pulmonary embolism nor stroke don't give any increase. But look to the mortality for cardiovascular disease. This was a fantastic study showing that the control group have an absolutely greater mortality in comparison to hormone replacement therapy treated group. Hormones are protective against cardiovascular mortality. Then we come back to the results that we have already observed in the different publications at the end of year 90s. And then from after that, we have the important contribution of Tommy Mikkola and all the Finnish groups who were using the facility that in Finland. They have a general record of all the data. Every individual have written all the treatment that they are doing during all the life. And then we have the beautiful paper published in 2015 on estradiol-based postmenopausal hormone therapy and the risk of cardiovascular and all-cause mortality. Then in that study, from Tommy Mikkola, Olaf Korkala, and all the group of Finnish friends, the risk of death caused by coronary heart disease and stroke among users of estradiol-based hormone therapy regimen in Finland, they evaluated nearly 500,000 of individuals, and the risk of coronary heart disease death was significantly reduced by 18 to 54%, not nuts, not 5%, by 18 to 54% in hormone user, and was related to the hormone therapy exposure time. The risk of stroke death was reduced from 18 to 39% and was not related to hormone therapy exposure time. Completely different results. And in another study, a group of Mikkola make a huge series of beautiful study. In 2016, Hanna Savolainen and Peltonen with Tommy, they published a study on cardiac death risk in relation to the age of initiation or the progestin component of hormone therapy. And you can see that these are all the data, the population divided according to the age at the initiation of the treatment and the number of people. And you can see the age younger than 60, less than 5 years, was associated with significant greater decrease in total coronary heart disease risk. And the conclusion were that estradiol-based hormone therapy are accompanied with larger coronary heart disease mortality risk reduction the earlier the therapies are initiated. The progestin component of estrogen-progestin therapy does not modify this timing effect. And you can see that in population going from 50 to 59, the protection was over 35%. And in the population from 60 to 69, and over the 25%. And still over 15% in the population starting from 70 to 79. Look how different is the message rising from this data. And in the other side, they, in Finland, they have since very long time, there are important use of vaginal estradiol to protect against vulvovaginal atrophy and genitourinary syndrome of the menopause. And they have seen that also the only use of the vaginal administration make a protection and a reduction of risk for cardiovascular mortality. Then the final message was in 1,000 women using vaginal estrogen for up to 10 years, a maximum of 24 fewer coronary heart deaths and 18 fewer stroke deaths is likely to occur. Then a completely different message in comparison to the possible risk of hormone therapy. And in fact, Tommy Mikola also have published in 2015 the analysis of the increased cardiovascular mortality risk in women discontinuing postmenopausal hormone therapy. What happened after WHI? That a lot of women, they stopped the treatment, even though if they were absolutely without any negative symptoms by the treatment. And in the discontinuation, they have found that in Finland, they have a total of more than 3,000 women deaths due coronary heart disease, in addition, more than those expected in treated women. Then, dear friends, this was pushing also the WHI scientists to reevaluate the study, and they published in 2017 that beautiful paper. It was Johan Manson as first author, who published that the menopausal hormone therapy and long-term all-cause and cause-specific mortality, evaluating the data of their Women Health Initiative randomized trial, evaluating the effect not only of the treatment period, but also evaluating the patient until 18 years of follow-up. They had 18 years of follow-up. And then they found that hormone therapy with CE plus MPA for a median of 5-6 years and CE for a median of 7-2 years was not associated with risk of all-cause cardiovascular or total cancer mortality during a cumulative follow-up of 18 years. And if you see inside to the study, you can clearly see in the study is referred, as you can see, the different mortality. This is all-cause mortality, coronary heart disease mortality, breast cancer mortality, and Alzheimer and dementia. You can see the first row is the estroprogestin, then estrogen only, and the total. You can see that when you have estrogen only, they also give a real better protection, not only not increase, but a better protection when estrogen only are given at all levels, at coronary heart disease, but also at the breast level and also at the brain level. And then from 2019, the timeline of menopausal hormone therapy start again with a new way. We know now what are the symptoms. We have symptoms in the central nervous system, who are vasomotor symptoms, lip dysfunction, depression and anxiety, cognitive changes, and migraine. We have symptoms specific of the menopause in skin, mucosal and hair changes, reduced skin thickness, reduced elasticity, hydration, increased wrinkling, and hair loss. We have symptoms in weight and metabolic changes, such as the weight gain, the increased visceral adiposity, and the increased waist circumference. Musculoskeletal system with joint pain and sarcopenia, and urogenital system with vaginal dryness, vulvar itching and burning, dysuria, urinary frequency, urgency, recurrent lower urinary tract infection, and sexual dysfunction, who means decreased sexual desire and dyspareunia. We will publish this in Nature Review. These are the real symptoms of the menopause. And each one of them, they are starting from what happened with increase in gonadotropin and reduction in gonadal steroid and inhibin. But each one of them is totally defined for the factors who are responsible of the symptom. For example, for vasomotor symptom and sleep disruption is the increase in central noradrenaline and the reduction in dopamine, serotonin, the increases in neurokinetics, peptine, dynorphin, and cortisol. And for the mood and cognitive function and the neuroendocrine activity is the effect of the increased noradrenaline and decreased dopamine, serotonin, GABAergic function, beta endorphin, reduction of allopregnanolone, DHEA, DHEA sulfate, androstenedione, testosterone, estradiol, and so on. And the same for urogenital symptom is all the important changes of estrogen and androgen. And for metabolic and cardiovascular changes, there are the increases in LDL cholesterol, but also increases in free fatty acid, triglyceride, cortisol, reduction in HDL cholesterol, sex hormone binding globulin, growth hormone, IGF-1, and so on. And also for muscular changes, the changes not only in steroid, in estrogen, but the changes in testosterone and the changes in growth hormone, IGF-1, IGF binding protein 3. And for bone remodeling is fundamental, the reduction of estradiol associated to increases in N-telepeptide of type 1 collagen, increases in C-terminal telepeptide of type 1 collagen, in pyridine cross-links, and all interleukin, TNF, and TGF. And for the skin aging, the reduction in estrogen-androgen ratio, the reduction in testosterone and dihydrotestosterone are fundamental for the skin and for the hair. Then, ladies and gentlemen, what is now the moment? Now is the moment of tailoring of the treatment and to have and to push to improve the adherence of the patient. This is fundamental. And we recently published with Tommaso Simoncini, Patrizia Monteleone, and Andrea Giannini a paper on human reproduction update clearly showing that in healthy women is at the lower part of the figure, in premature menopause and in surgical menopause, and in normal menopause. In healthy women, you can start with your therapeutic option, who are estroprogestin sequential or continuous, oral, transdermal, or transcutaneous, sex, tear, topical therapies. And then after 10 years, you can reevaluate, not stop, you can reevaluate, readapt, reduces the dosage, and continues to the treatment until the elderly. But in women who already have overweight or metabolic syndrome or hypertension, then biological risk, then you have to start with estroprogestin continuous or cyclical, but by transdermal or transcutaneous, not but oral way. Then we have to avoid the pass of the estrogen by the liver in patients who already have a metabolic syndrome, hypertension of any risk. And also, and then after 10 years, you can reevaluate, readapt. I remind you also the topical therapies and their importance in that maintenance. And what are the tips and tricks, dear friends? Choose the natural route of administration, vaginal or transdermal. Choose the right molecule, estradiol, to prefer vaginal progesterone, but women they don't like so much to be treated per vagina. Then if oral progesterone is preferred, choose dydrogesterone for cardiovascular disease protection and no breast stimulation. This is fundamental. And remind that menopause is a cause of frailty, vulnerability, diseases, changes in lifestyle, but menopause hormone therapy is the actor can totally protect the women from that. And then what are the new insights in healthy aging? First of all, remind it's important to activate behavioral intervention to improve quality of life. And menopause hormone therapies is not a replacement of lifestyle intervention, but in integrity. Remind primary prevention, tailoring of the treatment. We have a lot of window of opportunity, evaluate the contraindication, evaluate the risk related to comorbidity, and remind the availability of several and different compounds. We have a new concept about menopause, aging, and menopause hormone therapy. We have to rewrite the dynamics of aging processes. To maintain steroids means to maintain the course of nature. Changing is different than aging. And remind that no data indicated in women who well tolerate menopause hormone therapy who have to stop it. You can continue and you have to adapt to the patient needs. I thank all of you for your attention, and I am ready later on for all your questions. Thank you very much.
Many thanks, Andrea. It has been an excellent talk. Of course, couldn't be otherwise. You have presented a history and evolutive motion of the attention to menopause, how hormone therapy was the key in that evolution, and the good clinical studies, the very basic endocrinological studies of what we have learned in terms of tailoring treatment, something that I'm sure will be the topic of in the debate, one of the main topics. Now we move to the second speaker, and we have Dr. Katrin Schaudig, who is in France, in fact, today.
Yes, I'm in France right now, right.
So the title of her presentation is How to Approach Reluctant Patients to HRT, which is something very important for clinicians, because one of the main obstacles that we find is that many women don't really accept the option of hormone therapy. So, Katrin, the floor is yours, and we will. I'm sure we will debate a lot about the important topics that you will present. Many thanks.
Yeah. Thank you, Antonio. Thank you very much for the kind introduction, and thank you, Andrea, for this wonderful lecture. And after having heard all your data, the topic I'm about to talk to you is even much more important, because we have a great reluctance of patients towards HRT. And at this point, I also want to thank the company of Beatrice for the invitation to give this lecture, and also the invitation of the ISGE, which is presided by Andrea. Thank you very much, and I'm very happy to share some ideas about this approach with you. So here is my conflict of interest. Of course. So, and why is the topic so hot? And the data Antonio showed at the beginning about the pyramid of the population in Western Europe, where it was easily shown that the highest proportion of population is now around their 50s and 60s, which is exactly the age of women we are talking about. But what you always have to take into account in former times, and that is how nature and evolution designed women, they would not reach the age of menopause. So we have an increasing life expectancy compared to the average age of menopause. The age of menopause hasn't changed very much over the centuries, but the life expectancy has increased remarkably. And I was just wondering, Andrea, that one of the last slides you had with this old dame on the painting, and I wondered how old she was, because my idea was she probably was not as old as we would think about. Maybe she was in her mid or late 50s. So that we have to take into account. And like 500 years ago, women never would reach the age of menopause because they would die, usually in connection to childbearing, but also other reasons. So what do these women beyond menopause or around menopause complain of? Hot flushes are hallmarks of the menopausal transition. I'm still hot, but it now comes in flushes. But it is more than that. And there's a very nice description by the famous German author Thomas Mann, Nobel Prize winner. And he has described that in 1953 in a narrative very nicely. I will just share this quotation with you. For some time, her well-being had suffered from the critical organic process of her age. The gradual extinction of her physical womanliness continued slowly despite her inner resistance. It caused her anxious flushes, uneasiness of heart, headaches, days of melancholy, and an irritability that made her think of the gentleman's whimsical speeches as unbearably stupid. I'm sorry for that quotation, dear colleagues, dear friends. But anyway, but I think this is very nicely. And when you recall what Andrea just showed us, which systems in the body are impaired by the loss of estrogen, that really absolutely makes sense what we read here by Thomas Mann. The women's needs have changed. So even when you look at these women around their 50s, so these are really pictures I found from the internet. These women are all around 50. They look completely different to women nowadays. Women around 50 in these days have a completely different perspective on life. And this is not only a question of the life expectancy, but women's careers have changed. Women tend to appear more vital, more energetic around the age of 50, and they really want to maybe restart a new career, maybe start a new partnership, whatever. So this, the expectancy of women has really changed nowadays. But what are these women's fears? And that accounts to the data that Andrea showed about the WHI study. The scare number one of women is the fear of having breast cancer. And that, of course, has been fueled by the media coverage for the WHI study, but that is also very impressive, like what the Daily Mirror quoted when the 1 Million Women study, which also said that HRT is a very big risk for breast cancer. And when women see pictures like that, they're very much afraid. So what we encounter now with our patients is a hormonal dilemma. They have a hormone deficit, an infernal heat, versus hormone phobia and an infernal fear they don't want to take hormones. What are the reasons for patients' reluctance to take HRT? So I very often see these patients who suffer a lot, and that has also been quoted by Antonio and Andrea. About a third or maybe even half of the women have a big burden of suffering, and they cannot really cope with the challenges of life anymore. That's how they sit into our offices. But then they say, I do not want to take hormones. The media, they suggest hormones are just bad. What else is it? Misleading information about the safety. And you have to remember that the risks that have been shown in the WHI study are, by definition of the WHO, minor and rare side effects. These have been very few events, but the public information has been completely different. Besides that, there's a poor social opinion on hormones. And what really adds to the problem is that healthcare professionals are worse trained, and this has become worse and worse. So that there's another trend, so that is a very modern trend, maybe since 10 or 15 years, trend to organic treatment, whatever that means. For my opinion, hormones and estrogens are very organic, but for a lot of patients, they feel it's not organic. And then there's another problem, traditional thinking that is brought to the women by their maybe mothers or grandmothers who say, well, I suffered, you can suffer as well, or you just have to cope without medication, don't be a pussy. So there are a lot of influences that might explain the reasons for patients' reluctance to take HRT. Just to show you the German health insurance data, the prescription rate for HRT has been going down ever since the WHI. And in last year, only 1 out of 16 women between 45 and 65 has been prescribed HRT, in comparison to 37% in the year 2000. And yes, that pretty much reflects the 37%, the number of women who are severely affected by climacteric complaints. The risks are overestimated. And there's a very nice, I think, questionnaire that has been performed in the United States around the KEEP study. And they asked women, what do you think you will die of? And almost 40% of the women said, I think I'm going to die of breast cancer. So what are the actual causes of death? And that you can very nicely see. Breast cancer is 4% accounts to reasons of death. In Germany, it's even less, it's 3.5%. The main topic is heart disease. And as we have learned from Andrea's last lecture just now, you can prevent heart disease. And I very strongly believe in that if you start it early, if you start HRT early enough. But how do we deal with the fear of breast cancer? And I just go back to that. You see, there's a difference of tenfold between the perception of the risk and the real risk. So 40% think I'm going to die of breast cancer. Only 4% are really going to die of that for that reason. So first thing when you talk to your patients is you have to listen carefully, what she tells you, what her fears are, and you have to ask the right questions. Ask questions like, what are you afraid of? What are you most afraid of? And why is it so? And who told you this? So kind of try to get into a conversation with your patient about her feelings. Or ask the question, what would it mean for you if you got breast cancer? And sometimes I ask my patients, well, do you know women who have got breast cancer? Yes, we do know a lot of women who have breast cancer. And then sometimes I ask them, how many do you know who really died of breast cancer? Because if you detect it early enough, it is not a death sentence. But the most important thing is make the woman feel that you understand her anxieties and fears and that you really care. But if you don't do that, she won't even listen to you. So you have to find out how severe is the burden of suffering. And next thing, how big are the fears? And most important is you have to take the fears of the women seriously. And I always feel that it's very helpful if you make her feel that she's not alone with her problem, that she's not the only woman on earth who has these complaints, but also that there is help by taking hormones. But first you have to deal with the emotion, and then you can start to discuss the facts. The facts have been very nicely discussed by Andrea right now, so I'm not going to repeat this. But when discussing the facts, communicate the risks in an understandable way. The woman cannot really cope with relatives and percentages, but speak in absolute numbers. Discuss the individual risk factors. And when you remember the headline in the Daily Mirror, HRT doubles breast cancer risks. Funny enough, it implies in the women's brain every second woman who takes hormones will get breast cancer, which is of course wrong. But that is kind of the message that they get from these headlines. So when I say absolute numbers, this is a picture that we do show our patients. It's derived from an older publication from 1997. So the numbers have changed a bit. Oops, something wrong with my screen sharing? Can you see this slide? Yeah. Okay. Yes. So these are 1,000 points, which represents 1,000 women. And up to the age of 63, no, I'm sorry, up to the age of 70, 63 of them will have breast cancer. So nowadays, these numbers have risen by far. It's more than 100 now. But if these women take 5 years of HRT, there are 2 more cases in 1,000 women. If they take it 10 years, it's 6 more cases. 15 years, it's 12 more cases. Of course, it depends which sort of HRT they take. This is just a general thinking. In the HRT, in the WHI study, it was 3 more cases in 1,000 women after 5 years. But if I show my patients these pictures, they are kind of surprised. What? Only 2 or 3 more women out of 1,000 after 5 years. That is really something that convinces women that the risk is slightly elevated, but it is really only a slight increase. And with estrogen mono, Andrea showed that very nicely, no only little risk. The risk cannot be explained away. So, but how to deal with it? Early detection is crucial. So before you start HRT, make sure there is no breast cancer already by according diagnostic tools. After starting HRT, you have to counsel the woman that she gets regular examinations of her breasts. So what can be achieved through early detection? And I apologize because this is a German writing here, but this is the statistic of our National Institute for Statistics. And they say if the breast cancer is diagnosed in stage 1, we have a 5-year survival rate of 101%. It's hardly to believe this is statistic, but this is really amazing. And a lot of studies do show that when the breast cancer is detected early, you have a high survival rate. And the good news is that practically half of the breast cancer cases are diagnosed at a very early stage. So, and that is the reason why I always push my patients. So if you take hormones, just have your breast checked regularly, and most of them do it. What else can you do to make the women feel better about starting HRT? Choose an HRT with a probably favorable risk-benefit ratio. And that is what Andrea already quoted as well. We probably have a lower risk compared to the older data of the WHI study and other meta-analysis where the older progestin were used. So dydrogesterone and progesterone as progestins seem to have a much lower risk than the other progestins. Okay, so but here you can see now everything is fine.
Okay, yes.
Yeah.
Okay,
Yeah.
great. Okay, thank you, Andrea. So there you can see alcohol, 2 glasses of wine a day increase the breast cancer risk much more than HRT. The same applies for overweight or obesity. And again, with sport and regular exercise, you can decrease your risk. So that is something you have to take into account. There are ways to change the public opinion, and that is a very interesting development in the UK recently. So you see here the menopause warrior. So women have stood up for their rights in the UK. And interestingly, there has been passed through Parliament in October 2021, the Menopause Support and Services Bill. And that has been launched by Labour Member of Parliament, Carolyn Harris, who stated in front of the Parliament, menopause support in this country is falling short and failing women. GP training in medical schools, support in workplaces, public health messaging, and curriculum content in our schools all need addressing. Oops, sorry, here we go. And what led to the development in the UK, the public was made aware by female icons who came out in the media and came clean about their menopause-related issues. The conclusion was there's a large minority of women who have been lost as useful members of the society from working, from supporting their community and family, because they were frightened to take the very medication that would improve their quality of life and thereby the quality of life of those around them. And what you can see, this development in the UK has led to a distinct rise in prescription of HRT just by making the public aware how to deal with the problem. But it's not only the reluctance of patients, there's also a reluctance of physicians to prescribe HRT. And this is derived from a publication of Joanne Manson and Andrew Konitz from the United States in 2016, who were kind of shocked what the results of the WHI study, who Joanne Manson was a co-author of. Reluctance to treat menopausal symptoms has derailed and fragmented the clinical care of midlife women, creating a large and unnecessary burden of suffering. Most primary care residency programs don't provide adequate education in women's health in general or in menopause management in particular. And I think this is a development that has become worse during the years or decades after the WHI. And Joanne Manson says we must train and equip the next generation of healthcare providers with the skills to address the current and future needs of this patient population. And I think the training and the lectures like just Andrea did to show the data to healthcare professionals is, for my opinion, crucial. So the take-home message is there is still a great reluctance in women to take hormones, even when there is a great burden of suffering. The main obstacle for HRT use is the fear of breast cancer. There is widespread misconception of the risks and benefits of HRT. Appropriate education of healthcare professionals and women for the topic is crucial and needs to be intensified. in communicating HRT benefits, women's emotions have to be taken into account. I think that is a very important message. And with that, I thank you for listening.
Thank you.
Thank you, Katrin. Well,
I'm sorry that my presentation was stopped in between, but I hope I brought my message still.
yeah, it was frozen for a while, but I think the message is very clear, and I think we didn't miss anything finally. Okay, well, it is the time to start the debate, and I see that in the chat there are plenty of questions. We will try to organize them in order to give an answer for everything and also to have everything as clear as possible. So after those two fantastic presentations, I think that probably we need just to stress, as you, Katrin, just said, that menopause is something which is particularly important for women's life. Now that we are witnessing the interest for many of the areas related with women in general, women's health, probably menopause requires what you have presented that happened in the UK, in which there is an interest not only in obviously in the society but also in politicians and so on. So my first question is very general, and it is for both of you. Is if you just to start, if we want to set a sort of classification of the different options we have for managing the needs of women across menopause, if you had to choose a best in class, the top, would you say that probably HRT would be one of them? Probably the best, the most complete approach to those needs, because we have other options. For example, the selective serotonin reuptake inhibitors. We have treatments for osteoporosis. We have other options. We have even phytotherapy and so on. So would you like to raise a comment about that, Andrea?
Andrea, you start.
Yes, you know, I would like to start with an observation. Certainly, we can have treatment specific for any effect because inside to the various organs and cells, the lack of estrogen and lack of also other steroids can bring specific phenomena, symptoms, and can be corrected with a different treatment cell per cell. Yes, I agree with that one, but it is not our policy. A woman who have hot flashes, she don't need only a specific treatment to have to act on the neurons responsible for the activation of this phenomenon. She at the same time have a bone loss, but at the same time she have a changes in her mood, a changes in sleep, and she will have also disorders and symptoms correlated to her sexual activity and sexual function in a very young woman. Then she have a lot of changes who are touching a series of organs. Then I think the solution is to try to counteract using the same substance that nature have provided to the woman to protect all these effects. You have seen that the women are protected very strongly until the moment where her fertility is possible, because that protection was done in nature to achieve that we can multiply and can maintain our species. But after the loss of the reproductive capacity, this protection disappears. And this protection disappears because the factor that mean estrogens and androgens and also progesterone were important in women for all these activities at the various organ level, they can be protected again. Then my solution is to go toward hormones or toward all those substances who can maintain at the different level. While a woman, she have to protect again hot flashes, but not again bone mass density loss. Why? Why you have to explanation she have to die for the complication of a fracture? Or why she have not to protect the cardiovascular system? You know, I think we have to go following what nature is teaching us. This is my personal opinion. Katrin.
Yeah, thank you, Andrea. I totally agree with you, of course, as you probably expected. And I want to add something even more. You said, so a lot of the symptoms can individually treated. You know, you can give them sleeping tablets against sleeplessness. You can give them antidepressant. But these are also all drugs with side effects. And my personal opinion is, again, when all these symptoms are caused by a deficit in hormones, then it is, for my opinion, the most natural way to treat it with hormones by substituting it. I think this is very normal and it is very natural. Whereas if I give like SSRI or whatever, I also have side effects, not so well, these side effects are not so clearly seen in the beginning, but there are side effects. And I would always think it is much more natural to give the hormones. I think I'm very sure about that.
Andrea?
Can I add something? Yeah. I would like to follow Katrin, not only to add, but also to have that opportunity to discuss with the patient. You are overweight. You are eating bad food. Why you are eating bad food? You can choose good food to live longer. Why you are overweight? You increase your cardiovascular risk. You have not to take the car to come to my consultation, but you have to walk. You have to walk outside. You have, you need a more healthy quality of life. We have to spend more time to push our patient to have an healthier quality of life and to reduce the amount of food and to increase the quality, the movement, and to increase all the physical activity. It's not needed to go to have a personal trainer. No, right. You have to go walking. You have to go walking. When you go to buy something, you have to go walking. Step down from the bus 500 meters before, you will see also the other shops and you will walk. I think we have to speak with them. And also, I would like to, I go in line with Katrin, right, to have her comment. You know, the marital life is not only when you are 20 or 30 or 40. Marital life also when you are 60. And sexual life, marital sexual life positive at 70, at 80 is fantastic. Is fantastic for your self-esteem, for your perception of living. You know, this is something. You have seen the slide that Katrin was showing us, the Katrin of the difference of what the women they were, what they are now, what they expect now. And, you know, the sexual disorder and the reduction in sexual activity. But how you can have a sexual life without them, the hormone who maintain the genital trait, not only the estrogen, but also the androgen. Because in addition to what we have spoken about the loss of gonadal steroid from the gonads. But remind, we have not spoken, you have also reduction of delta-5 androgen and delta-4 androgen from the adrenal at the same time. We have also in men, but also in women, you have also that one. And then the lack of hormones is changing, and the lack of hormones is changing in the deep of its effect, and is touching women and men in most aspects of our daily life.
Yeah, I totally agree with that, Andrea. I'm sure, yeah, absolutely.
Okay. So we have a few questions about this area. I try to organize them, but firstly, I have here a question from Dr. Parsons, who asks, which is the relevance of the window of opportunity for initiating the treatment? Katrin, for example?
Yeah, well, the thing is, I think if you really want to take with you the side effect of besides, you know, treating all these symptoms, and you say, I also want to take with me the cardioprotective effect, I think you shouldn't start too late. I personally think it's about 1 to 2 years, maybe 3 or 4 years. But this is very individually different because some women have, after the real last menstrual period, still a certain amount of estrogen, which probably protects them. some women don't have any estrogen at all with the last menstrual period, so that differs. I would personally think, I don't know, Andrea, what you think, that probably 1 or 2 years would be fine. I wouldn't think that much longer is sensible, but you have to be careful. Sometimes I see patients who really suffer a lot, who tell me, I've been suffering for 6 years now, and now I'm fed up, and I know now I want something. But my doctor said, it's not sensible to start now. It is harmful for my heart. I wouldn't agree with that. The only problem is after 6 years of gap, you probably don't really get this benefit for your heart anymore. We really don't know that. Or maybe, Andrea, you know studies, but I think it's not really clear. And but they still can start when they suffer for 6 years. I don't see a point why they shouldn't start with a transdermal, preferably HRT then. So that's my opinion. But the gap shouldn't be, the window of opportunity, I think, shouldn't be longer than 2 or 3 years.
Well, I thank you very much, Katrin, and I agree, but I would like to go more in deep. You know, when menopause when arrived the menopause, when you have your last menstrual period, this is not preceded by a normal ovarian function until the latest moment. Ovarian function is lost in a very personal, different manner. In some individuals, you have long period of low estrogen. In others, you have period of high estrogen. The first part of the cycle, which is deranged by this aging process, is the luteal phase. And in the luteal phase, you have a shortening of the luteal phase, or you have a reduction in progesterone production from the corpus luteum. Then what I think is, if these symptoms start earlier than symptoms of menstrual cycle disorder, we have to start treating that one. And for example, if you remind that progesterone is the factor who inhibit the ovulatory LH discharge, for example, dydrogesterone don't have this effect. And then you can use dydrogesterone as luteal phase support, also starting from a fixed date, independently by the fact that you are waiting the moment of the LH peak, because the changes in the structure of dydrogesterone in comparison to progesterone bring to a molecule who have no effect on gonadotropin production. Then I think luteal phase supplementation in the early premenopausal time is also important. And in my personal view, Katrin, I start absolutely earlier. I start since the late ovarian function time. Since that moment, I try to correct the menstrual cycle disorders and to maintain. And it's very personal. I make also blood exam. I check what is the androgen concentration, because the women, something which is absolutely, we have forgotten that one until now, Antonio, is the fact that the women, they are also losing androgen in comparison to the androgen at 20, when they are full of sexual thoughts. At 40, they have already lost 50%. At 70, they have lost 80%. Then I think also sometimes we can have some importance also to have an evaluation of what are the real estrogen that the woman have, what are the real androgen. And then we can tailor the treatment. We can start the treatment even before menopause. Start the treatment before menopause, accompanying them, avoiding all period of symptoms of menopausal transition and going on. This is my personal strategy. I don't, certainly, probably it's too complicated, but it's what I am using for my patients.
Well, but Andrea, I do the same. I do really the same. I was just, quoting this patient who has tried to get through it without medication. Usually the patient who comes and says, well, I start having irregular menstrual periods, I start with sleeping problems, and I start with psychological problems, and they don't have hot flushes. And I totally agree. I would start them on hormones as well. I do the same. And I think the shorter the gap, the smaller the gap,
absolutely,
the better. And I know these studies, which I think are quite impressive, that probably what accounts for the cardiovascular system in terms of protection probably also accounts for the brain and the prevention of dementia and Alzheimer's disease. And we all know that the study situation, the data are inconclusive, but you know, seeing all the data we know and seeing histological studies and cytological studies of neurons and everything, I personally strongly believe that you should get a big gap with an estrogen deficit in terms of your brain. That I'm pretty sure of.
Okay. Well, we have now one question for each of you from Dr. Löfqvist. She's a gynecologist from Sweden. Thank you for your interesting presentations. The question to Professor Genazzani. I have listened many times to your presentations about androgen substitution for women with loss of libido and about the benefits of oral DHEA substitution, if needed. In Sweden, our national guidelines, we have to choose transdermal testosterone for women with androgen deficiency. There are no accepted testosterone preparations available for women in our country, but we can prescribe DHEA for treatment of vaginal atrophy. Is this really enough when for women with clear need of androgen treatment? What do you say about the treatment with oral dihydroepiandrosterone?
Thank you very much, Dr. Löfqvist. I thank you for that question. This is something that I have studied for the last 25 to 30 years of my life. You know, I think that a supplementation with oral DHEA have to be based on circulating concentration of DHEA sulfate. Once the DHEA sulfate, who is normally in the younger times in women around 2.5 to 3 micrograms per milliliter, go down to 1.3, 1.4, I think we have to restore. This is my view. I restore DHEA based on the DHEA sulfate concentration, starting with the oral dose, a daily oral dose in the morning time of 25 or 20 or 15 or 10 or 5 milligram, according to the need of the patients, and reevaluating every 6 months what happened. Also, because I'm sorry if I take 1 second more, also our study shows that the DHEA administration going on, if it is for a long time, this modify the adrenal steroidogenesis. This push up again the adrenal to produce its own DHEA and other and progesterone. And then this is a very important effect. The vaginal effect of DHEA is also very important, but these do not modify the peripheral circulating concentration either of androgen or estrogens. But at local level is important because have not only effect on the mucosa, rising the maturation index as estrogen, but it acts on the lamina propria and on the muscular tissue. And you know, the vagina is not only a mucosa, the vagina is an organ for a coital activity. You need a well-structured organ with muscular structure also for the orgasm, and also the lamina propria and connective tissue have to defend the structure of the vagina. And you can obtain that one by estrogen, but you can obtain that one by DHA. You know, we also don't have any testosterone now. We are using sometimes testosterone in elderly population to protect external genitalia. External genitalia are from ectoderm origin, and they are sensitive to androgen, not so much to estrogen. Then to have a reconstruction of the genitalia, you know, the labia majora, they disappear progressively during the life. With the local testosterone, we give a local testosterone ointment with a dose of 0.5 milligram twice a week to maintain the reconstruction and to permit the reconstruction of the genitalia. It's not a rejuvenation, it's a reconstruction of the labia majora and minora. I'm sorry, it was probably too long, but I strongly believe that women have to be taken, we have to evaluate also their androgen condition, and we have to protect, as we do with estrogen, we have to protect also with estrogen.
Well, it's a very interesting topic. And the second question is for you, Katrin. Dr. Lofquist is asking about what would you recommend to do when you treat women during the perimenopause with sequential hormone treatment and they bleed at unexpected?
Well, that's a very important question. And I think the real challenge is treating women in perimenopause because exactly of that. The problem in perimenopause is that the ovaries don't react on the regulatory mechanisms, you know, all this wonderful dialogue between the pituitary gland and the ovary, and that doesn't work anymore. So we have nice studies that show that you can have ovulations every 2 weeks in this period, which usually would never happen, because usually in the luteal phase, in the woman in her fertile years, you wouldn't get a second follicle to start to grow. But obviously in perimenopause, that is exactly what happens. During the luteal phase, a second follicle or even a third follicle may grow. And you can see that when you perform an ultrasound of the ovaries, sometimes there are like 3, 4, 5 quite large follicles, and you think, oh my God, she's got an ovarian cancer, but she hasn't. So that is really a problem. Of course, you always have to exclude a uterine pathology by ultrasound and maybe even by a biopsy. That is kind of crucial for me. So, and if the woman is at higher risk for a pathology in her endometrium, like obesity, hypertension, diabetes, you should be especially careful if she doesn't have that all, and you think the whole problem is because of a deregulation of the axis, and maybe then progestins like dihydrogesterone or progestin, which might help to make a transformation of the endometrium, they won't kind of cut down the activity of the pituitary ovarian axis. And in these cases, we sometimes like to use the older progestins to make a regulation and to have an anti-gonadotropic effect, at least for a couple of months. Like you can give that cyclical, you can give, well, we have clomidinone acetate in Germany, which is very nice for that purpose. Like you can give it cyclically, you can also give it for like 2 or 3 months on a daily basis, just to kind of regulate down the permanent stimulus of the ovaries by the FSH. That works, for my opinion, quite nicely. You don't, well, I mean, if the woman is not at risk, you could take a contraceptive pill with natural estradiol if she is allowed to take that, just for a period of time, not for on long term, but maybe for 3 months, 6 months. So that's how we deal with that.
Thank you, Katrin. I think it was very clear and very informative. Now we have another question from Dr. Stein. Well, it's a question, a crucial question, I would say, because it's very brief. The question reads, with all the advantages of menopausal hormone therapy, why should a woman ever stop it?
Andrea, it's your turn.
You know, my last slide have that comment that no study has shown now that a woman which is well under treatment with hormone replacement therapy, which is adapted to her body and mind, they have any reason to stop it. They don't have any reason to stop it. I have in my practice, I was working in the Tyra Syndrome time, I have in my practice a huge group of people over 80s and a small group of people over 90s still living well, with but continuing a treatment with different small doses of estrogen and progestin. And I don't have any reason to stop that one. I think they will stop the treatment, they one day will stop their life.
Okay, Katrin?
Yeah, I think it's a difficult question because I do the same as you do, Andrea. But we are acting against the guidelines. And that is a bit of a problem. I mean, the German guidelines say you only take hormones as long as there are complaints. So what I discuss with the patients, try to stop it for a short time or reduce the doses. But at the end, and sometimes, and this is something which I should not be officially quoted, but I tell them, so ask me as a woman and ask me as a physician. As a physician, I have to tell you, well, the guidelines say stop it as soon as you don't have any problems. And as a woman, I would say continue, but that is maybe unprofessional, but that is the point. I mean, regarding all the data you showed, Andrea, I agree, no. but I mean, you still have what I tell those women who continue to take it on the long term and who sit in front of me and say, I'm feeling perfect and I don't want to quit. And that's fine with me. And I say, well, I will take that with you. The only thing, take care of your breast. That is something I really push. I say, go regularly to examination, because I think even with progesterone on a long term, micronized progesterone, we might have a slightly elevated risk as it is with women who have a very late menopause compared to women with an early menopause. So that is really a biological effect, which the evolution didn't account for, because women wouldn't get so old. I mean, you can ask yourself, why did evolution do that? So always have a close eye on the breast. And if you do that, it's fine on a long term. I don't mind, but it's the decision of the woman.
Well, then there is a general point. I think probably we all agree that the best thing to do is to prevent from that. The question is, what can we do for smoker ladies?
Smoker.
The best option is to stop smoking.
To stop smoking.
Quit smoking, very good idea. But you see, Andrea, what you said before, that you said, well, counsel them about physical exercise and so, but that is something that impairs their convenience, you know? They don't want to stop drinking alcohol, they don't want to make physical exercise, and they don't want to whatever, they don't want to lose weight. So that is something which they don't want to. So that's a problem. But I would give the smoker, I would put on transdermal. I think that that's pretty clear, because she has elevated risks. Alfred Mück made a nice study that he kind of has the hypothesis that when the women, the smokers take the estrogen orally, it promotes the metabolization into genotoxic metabolites. So he, and also the effect, for instance, on the bone is much less with oral estrogen than with transdermal. So if she can't quit smoking, then put her on transdermal. What would you say?
We have also tried to push them to artificial smoking. Smoking, which is an in-between. It's not to stop, but you have, because sometimes it's the habit to, and then we use that one, and then after that we start, why you don't reduce the number per day, and then we try. I think it's very important that we maintain a discussion with the patient. And then as normally they are well under treatment, and then the reduction of smoking habit, the transition from smoke of cigarette to the smoke of artificial cigarette, and later on to modify the content of artificial cigarette, this is also the strategy that we use.
Okay, then another question, this time from Dr. Laura Trujillo. Asking about why to use intravaginal progesterone, because she says, isn't it uncomfortable for the woman? What is the difference between oral and vaginal administration?
I think this is a fundamental difference. Because oral, God or nature have originated the progesterone production from two glands, the adrenal gland and the gonads, and have pushed that one to vena porta, to vena cava, not to vena porta. The vena porta take the blood from the intestine and bring it directly to the uterus. To the liver. The liver cells, they have two phases. In one side, they receive the blood from the vena porta, and then this blood is completely metabolized. In the other side, they receive the blood from liver arteries, and this blood is used to oxygenize the cells and to bring nutrient to the cells. Then, if you put the progesterone from the side where it's coming from the intestine, it will be metabolized. It will be strongly metabolized, mostly to allopregnanolone and other metabolites of progesterone, who have also different effects. We believe that it should be given per vagina. If the women, they don't like the vagina, they have to take another oral progestogen, which is dydrogesterone, which have a structural difference and who is devoted from the possibility to be metabolized to allopregnanolone and in other progesterone. You know, dydrogesterone, even you don't measure in the radioimmunoassay when you measure progesterone, because this difference in the structure make it a different molecule. It have the same effect on the endometrium, absolutely, but it don't have effect on the brain.
Yeah, I agree. And the problem is, I think that with oral progesterone, maybe the transformatory effect on the endometrium is not protective enough. That's the point. But if she wants to swallow, I would eat, and then I rather give a higher dosage to kind of, you know, a little bit is not metabolized, but the metabolized progesterone won't transform the endometrium.
Yes.
Okay. Thanks. Now another question. Well, Andrea, there is plenty of questions, and we are approaching. Shall we take a little bit longer?
You can. It's a pleasure. We have still 235 participants with us.
Okay. So, because there are plenty of questions. What is the TSEC? And this is a very general question. What is the TSEC, and which is the role of estetrol in menopausal therapy? It's Dr. Antonella Vitturini.
You know, the role of estetrol can be a fantastic estrogen. It's an estrogen which is normally present only during pregnancy. Then you have to believe that it's the safest of the safest. It's counteracts some effect of estradiol, but it have also some effect similar to estradiol. And I think it should be considered very positive. But until now, we don't have sufficient studies. It's not present, then the number of studies published on estetrol in menopause, they are absolutely very few. And I think we need more experience about that one, but I think it have a good future because it's devoted from effect on the breast, or the effect on the breast are absolutely with minimal in comparison to the other estrogen. And then also the effect of the breast, that means that also it can modulate differently the effect of progesterone on the breast. And then I think it should be very, very interesting, but we need more data. This is my view.
Do you have an idea, Andrea? I would always love to ask you that. We don't really know what the role it's a fetal estrogen. Yes. And we really don't know why nature is only doing it in the fetus and what it is for, right?
I think
still don't know it.
No. I think if you go on the observation that the concentration of estradiol at the end of pregnancy are of around 20-30 nanograms per milliliter, yes. While at ovulation a woman she have 350 picogram. It's a too high estrogenic condition, and estetrol can act as to protect the fetus, the male fetus, but also the female and the woman from the too high estrogen concentration. I think it's a modulator of estrogenic activity. This is my perception during pregnancy.
Interesting. Mm-hmm.
Okay, now another question here from Dr. Rios, Katiuska Rios. There are two questions. One is very general. Is there clinical research in the follow-up of patients who use the chip of testosterone? And also about the so-called bioidentical hormones.
You know, this is, you know, the history of bioidentical is to be identical or not identical. The chip of testosterone, there are not yet sufficient studies about that one, and we don't know what are the real. We have no dose studies related to the dose which can be used in the women for androgenic effect, and then, you know, the women, they reduces their testosterone during elderly and during also the midlife. But what is really reduced is the dehydroepiandrosterone. The HEA sulfate is reduced from to reaching concentration of only 10% of what it was. Testosterone is reduced of 20–30%. It's not, and also you don't, the evaluation of circulating testosterone in women have poor impact, have poor role to understand the sexual behavior and sexual activity. No studies have shown that the critical difference between a woman who have 200 picograms or 300 picograms or 400 picograms of progesterone, while you have important difference if you have only half of estrogen or 1/4 of estrogen. You know, testosterone circulating concentration is not so clear for its clinical impact.
Thank you. Katrin, there is a question for you now, also from the same doctor, Katiuska Rios. I think it is more important to convince doctors to indicate hormone therapy. Many times it is our own colleagues who advice is used due to thermos. There are even studies on the matter. I know that you are interested in that area because we have shared something about that. Yes. Would you like to comment something?
I totally agree with the colleague. I mean, that was in my last slides that I said it's the reluctance of the physicians, but the topic of the talk was the reluctance of the patients. That's why I didn't put so much impact on that. My personal feeling is what we have now, and that is something, at least I observed that in Germany, the training of endocrinology is very poor. It's not well enough, and we try to improve it. And the problem now is that the knowledge that the healthcare professionals get about hormones is what we would call a half knowledge, and it's kind of really, you know, diffuse. You know, it's not so like, oh, it's kind of bad, and if it's kind of bad, we better don't use it. You know, it's very, for my opinion, it's very unprofessional. It is what like GPs in Germany say, what internal medicine doctors say, and tell their patients, so better don't take it. That is, I think, very dangerous because it is a lack of data that these colleagues have, and they more believe in the headlines of lay press and lay media, and not so much in the real data. And we all know even the scientific data have been exaggerating the facts of the WHI study. So I totally agree. We have to work on the education of healthcare professionals. That has been, I mean, that has been a challenge in the UK, that this Labour member of parliament say we have to improve the training of healthcare professionals. I totally agree. I think we have to try to enhance the knowledge in our colleagues. That's what we do all day long, don't we, Andrea? We try to improve the education.
If I can add something, Antonio, just to mention, ISG, the International Society of Gynecology and Endocrinology, have a special school, and the special school will activate a course on menopause and menopause hormone therapy starting the beginning of October, with 18 fantastic lessons on these topics. I would like to suggest all of you to reach to ask to ISG and to reach this course, because this will answer exactly what Katrin is telling us. Also because we have a lack of education. WHI have pushed the menopause in a corner, and by that way, They are doctors which were graduated in 20 years, from 2002 to 2017. In 15 years, they never had any positive, any news, some of them any news, only a descriptive news of what is the menopause. But menopause therapy was something which was completely forgotten.
Yes.
Okay. Another question. Well, there are plenty of salutations, congratulations, and so on. I'm jumping over those questions. And now there is an anonymous attendant. In Sweden, we have a common opinion among patients that there is a great risk using HRT in breast cancer, and that it is important to use bioidentic progesterone, which results in self-administered progesterone in cream, which they buy online. Your comments and how is it in your countries? Andrea?
Well, first of all, in patients who have a breast cancer, it is still existing a contraindication to hormone replacement therapy because we have not yet sufficient data. In future, probably we will have effect on estrogen-only treatment in high dosage in patients who have a lack of sensibility to other treatments. But the idea to treat with progesterone, with what we know in the biology of the cancer, on breast cancer, the more risk factors is the progesterone, it's not the estrogen. The estrogen raises the mitosis of all the breast cells, while the mitotic index is increased in cancer by progesterone. Then, dear friends, forget it, progesterone. Until now, I cannot tell you more that if a patient have a breast cancer, unfortunately, we have to go to other treatment. This is the reason why with Katrin, we are discussing about specific treatment for the symptoms, specific symptom for the hot flush, for the sleep disorder, for the anxiety, for the bone, for the vagina, but not hormones. This is until now, but certainly not the progesterone.
Okay, Katrin,
Yeah,
now another.
but what I understood from that question, Antonio, was that she asked for transdermal progesterone, right? Or did I get that wrong?
In cream, probably vaginal
yes.
cream.
The
It doesn't say.
Yes.
Yeah, but that is transdermal. I think she means the transdermal. We have the same kind of movement in Germany, and it is clearly shown that transdermal progesterone does not protect the endometrium sufficiently if you also administer estrogen correspondingly. So a patient who is treated by estrogens, she will not have an adequate protection of her endometrium when she takes the progesterone as a cream transdermal. That is clearly proven, and it is against all recommendations.
Okay, now, Katrin, for you, can we prescribe HRT before menopause if FSH is higher than 30?
Well, that is again the question of the perimenopause. You know, I mean, the measurement of the FSH, that is just 1 point, you know, that can be elevated once and then it is normal for the next month or years even. I wouldn't really make my indication for hormones from the lab results, but mainly from the symptoms that the patient has. And of course, you can start in perimenopause when the ovaries are still working and the patient is bleeding more or less regularly, but you really have to check how much activity is there in the ovary. Is the ovary overactive, which happens in perimenopause, or is it not? And sometimes you can start very nicely with the cyclical administration of progesterone or dydrogesterone, or if the ovary overreacts, you may have to regulate it down. It is really, I think it's a very difficult phase. And then, you know, what happens is the patient comes and says, well, I was on hormones, but I didn't tolerate it. I had a lot of bleeding and I didn't feel very well, but that was because the ovary was acting against the HRT, and that is a problem. You have to kind of just check it with examining the patient and taking a thorough history. It's a difficult phase. There is no standard solution for this phase.
Now we are going to a close because, well, there are some more questions, but they go back to the same points. There is one here, Dr. Hansen, for you, Andrea. The point is that some patients are reluctant to take progesterone indefinitely, and they do not show any bleeding anymore on cyclical progesterone. So is progesterone actually needed 10, 15 years after HRT has been started, or can progesterone be discontinued?
You know, we don't have any data, any study showing that you can completely discontinue. You can reduce the dose. You can go, for example, with dydrogesterone to very low concentration, to 2.5 milligram of dydrogesterone, or even 1.25 milligram. You can eventually administer it for 2 weeks, every 4 weeks, or every 6 weeks to reduce in patients who don't bleed, you can examine the endometrium thickness by the ultrasound. If the endometrium remains very thin, you can postpone the administration. But my suggestion is to maintain a weak protection with progesterone, or with dydrogesterone oral administration in reduced dose, because we need more data to be sure that you can continue forever without any progesterone protection.
Okay. Now,
yes.
Another question for you, Katrin. Dr. Yogaraja, a lady, 46 years old, total abdominal hysterectomy and bilateral salpingo-oophorectomy, used HRT for 5 years and stopped 1 year ago. Now she came back with several postmenopausal symptoms. Can we restart HRT, and how long she should use further?
She's 43. Did I get that right?
But 46.
46, but she's below 50. So, I mean, for my opinion, it is really, you really have to treat those patients with a bilateral oophorectomy below the age of 50. You have to at least treat them until the average menopausal age, and after that you have to restart the discussion. Do you want it or not? But up to 51 or 52 is crucial to continue for the protection of heart, for bone, for brain. So I think there's no question. Do you agree, Andrea?
Yes, also because if she can be treated only with the estrogen.
Yeah, absolutely.
Only with estrogen, then you have you have no any increase in breast cancer risk. Then estrogen support provide a beautiful protection of endothelial cells, and then cardiovascular protection, beautiful protection for the bone, beautiful protection for the genitourinary tract tissues, and also, you know, and I don't see any reason to stop it. If they don't take progesterone, I don't see any reason. This is why I continue in these patients until elderly.
Absolutely.
Very late.
Okay, and now we have a last question. What about Mirena as progesterone support for both of you?
Why not? In the menopausal transition, Mirena is very convenient. If the woman she have any excessive uterine bleeding and so on, Mirena is very positive. You can use Mirena with a transdermal estrogen.
Yeah, I see the same. And you have contraception. It's a safe contraception, and so and you don't bleed. So it's wonderful. And it's definitely, there are good data for that. It's definitely sufficient for the endometrial protection.
Yes.
Okay. Well, there were some more questions, but unfortunately, we are at the very end. 15 minutes later than expected. So this was a great success. Many thanks to both of you for the excellent talks. Many thanks to Beatrice for the sponsorship, and to the International Society of Gynecological Endocrinology for these excellent webinars, which so much help the formation of so many doctors in our specialty. So many thanks, and have a very good rest of the day or the afternoon, wherever you are. Many thanks again. I don't know if you want to add something.
Just to remind you, if you have a real interest on menopause, please follow the course of the International Society of Gynecological Endocrinology, especially devoted to menopause hormone therapy.
Yes.
Okay. So many
and
thanks.
I thank you all. It was a great pleasure to
Thank
have
you,
this
Katrin.
lecture.
We will see each other in Lisbon. In Lisbon, we will meet at the International
Bye.
Menopause Society Conference.
Bye bye. Many
Okay.
thanks.